Let's talk Chapter 5 Chronic Illnesses and Older Adults. What is the difference between an acute illness and a chronic illness? An acute illness has that rapid onset, with often a short duration, a return to the previous level of function after treatment, everything such as colds, flus, GIs, minor viruses. On the other hand, chronic illnesses, these are prolonged illnesses, often have no cure, result in irreversible changes, possible disability, maybe even requiring rehab or long-term medical management and nursing care. Everything from arthritis and diabetes to stroke, heart failure. And keep in mind, as the population ages, more older adults are living with more than one chronic condition. And these chronic conditions often account for 70% of all deaths within the United States. Chapter 2 here includes a figure from your textbook, and that's the chronic illness trajectory. And it's a theoretical model of chronic illness. This trajectory, begins right there with that onset of illness and through the acute stages versus as it extends out into more of a chronic illness. Your textbook lists 7 tasks of chronic illness. The first is preventing and managing a crisis and understanding the potential for the crisis and how to prevent or modify that threat. The course of that illness is not necessarily completely stable. Say it's in long-term pain. That pain level of that patient may vary wildly in exacerbations and drastic increases in that pain, and then decreases where it's more manageable. The next is going to be carrying and prescribing that treatment regimen, carrying out that prescribed treatment regimen. Are they able to care for themselves? How much assistance and help do they need in managing this illness? And finally, controlling symptoms, modifying lifestyle changes, especially when it comes to things like diabetes and hypertension. Making those necessary lifestyle changes is going to go a long way in prolonging and improving the course of that illness. Time management may also play a key role in managing that chronic illness. Changing their schedule, changing activities of what they do. If this patient starts to develop arthritis, they may no longer be taking the long, prolonged walks and hiking that they used to once enjoy. And helping that patient to find ways to spend and occupy their time in ways that they can accomplish with their current illness, because they may need to make adjustments and lifestyle changes. And adjusting the changes in the course of the disease. What could begin as a manageable chronic illness could slowly progress and to become much, much more debilitating for that patient. Also preventing social isolation. This shouldn't be overlooked in both chronic illness and especially for the elderly in general. Preventing that social isolation. If they get a disability, they may not be getting out of the house near as much as they used to. And that may mean they're missing a lot of the previous social interaction they once enjoyed. And finally, attempting to normalize interactions with others and finding ways that they can socialize and get out in a way that can still accommodate their illness. As you're probably figuring out, you're going to see the terms primary, secondary, and tertiary come up a lot in a lot of different aspects of nursing. In this case, we're going to be talking about that primary, prevention, diet, exercise, immunizations. These are going to be primary interventions to prevent that chronic illness. Versus, in this case, secondary is going to be early detection, screening. We're going to identify that problem early. Secondary is going to occur after the disease has occurred. So for primary, we're preventing that hypertension. Versus secondary is going to be early detection and screening for that hypertension. And then moving on to tertiary is going to be rehabilitation, treating that hypertension after it's occurred. The course of a chronic illness is often unpredictable and can profoundly affect the patient's family, lifestyle, and every activity of their daily living. And you as a nurse are going to play an important role in that, both assessing symptoms, identifying potential problems, identifying potential limitations, and you're going to do that through a complete history, a physical assessment, teaching the patient and caregiver about treatment plans, how to maximize their effective both activities of daily living as well as the instrumental activities of daily living. Who knows the difference between ADL and an IADL? An activity of daily living is going to be an example of the more basic, the feeding yourself, brushing your teeth. versus an instrumental activity of daily living is going to be the more complex. Going out and buying the food, going out and buying the toothpaste, or going out to taking yourself to the dentist's office. And all of these are going to be necessary to maintain a high quality lifestyle. A subject we've briefly touched on already is demographics and the rapidly aging average within society. The fastest growing age group within the U.S. is the 85 plus. And that's projected to increase from 6.5 million in 2017 to 14.4 million in 2040. And as we age, we require more and more health care. There's going to be more and more resources need to be delegated to this age group. There's going to be things we can do to help improve that. A greater emphasis on health promotion, preventing problems before they occur, disease prevention, early detection. Because it's always better to treat an illness at its earlier stages. We can greatly reduce both the toll that would take on the patient, as well as the resources they would require from the healthcare field. People are living longer and longer than they used to in previous generations. Those reaching 65 have an average lifespan of an additional 20.6 years for 18.9 for men and 22.3 for women. They just seem to last a little longer than we do. Over 52 million, or 16% of the population, were aged 65 plus in 2018. And this is expected to reach 95 million in 2060. And these trends are not expecting to reverse anytime soon. There are a lot of factors. We are greatly improving our healthcare. We are greatly improving, in some senses, our diet. There's a lot of concerns in our modern diet, and that we are not eating the quality food that previous generations did. But we also have a lot more knowledge about healthy lifestyles, healthy eating. And these are combining with the increases in technology, medicine, imaging, early detection, and screening. And people are hopefully continuing the trend of living longer and longer into the future. How can we define and differentiate between our elderly population? First is going to be what's categorized as the young old adults, and these are 65 to 74. They're typically healthier, independent, still have good cognitive function. And then you've got your old adults. These are the 85 plus group. Often widowed, divorced, single female, dependent on family for support or care, who has outlived their children, partners, siblings. And there may be many that are lacking in the support that they need out there. And we really would need to be assessing that and doing everything we can to make sure that we're not just sending these patients off on their own. Because there can be some very terrible living situations for our elderly out there. There can be many different attitudes towards aging. And we need to understand that aging is normal. Aging is influenced by emotional and physical health, developmental stage, socioeconomic status, culture. There's a lot of factors that make a part in how healthy that person is in their elderly years. Have they been a lifelong drinker? Have they been a lifelong smoker? Have they been exercising throughout their life, or are they living a sedentary lifestyle? And it all really does build up and play a key part throughout the lifetime. Unfortunately, ageism is normal. It has a negative attitude, perhaps related to fearing for your own aging process, lack of knowledge about aging. People want to hold on, and we need to understand that aging is normal, and helping the patient feel comfortable with that, making sure the patient isn't embarrassed to tell you about issues that they're having. Make sure that they're comfortable telling you that, I used to be able to read things just fine, and now I cannot see the labels. Or I just don't have the finger dexterity to open my medicine bottles. You want your patient feeling comfortable to talking to you and telling you their problems, and not feeling embarrassed and afraid to hide them. That biological aging, it's a reflection of, again, that nature versus nurture. It's going to be both genetics combined with diet and environmental contributions. I actually used to work with a nurse. She was still working in the floor in her 70s. And it was kind of a sad situation because, yeah, they had great genetics, but she had a husband who was at home very sick. She also had a father in her 90s at home who was healthier than the husband. And yeah, we all applaud. This is amazing. She's still able to work the floor. But it also had a sad aspect that she kind of had to work the floor as well. And yeah, she had that great genetics. I mean, I would kill to be half that healthy in my 70s. But yeah, there's also another factor of lifestyle as well. Again, good nutrition, exercise, stress management. High stress can have debilitating effects on people. And it all combines together to make them who you are at every stage within your life. Living and managing chronic illnesses is an issue that's unfortunately going to affect almost all of us. And daily living with these chronic illnesses is a reality for many, many older adults. Everything from cognitive, Alzheimer's disease, vision and hearing deficits, osteoporosis, Parkinson's, depression. Hypertension is possibly one of your most common, especially here in the United States. Heart disease, diabetes, cancer, stroke, COPD. These are all debilitating complications that have their own unique considerations and challenges to successfully manage. Another demographic that unfortunately gets left out a lot when learning about disadvantaged populations is the rural population. I live in Cleveland now, but I grew up in far southern Ohio, out in a rural county outside of Huntington, West Virginia. So I understand the challenges that they can face. There's certain areas of West Virginia where you drive 3 or 4 hours just to get to a hospital. I'm sure you've got plenty of those areas out in Texas as well, where you can get significantly far out there. And how can that patient get where they need to go? Transportation can be a major barrier, especially as they get older and may be unable to continue driving themselves. How can they get to those appointments to manage themselves? How can they get to the grocery store to feed themselves? Preventing that social isolation. You start living farther and farther out there, the houses are farther and farther apart. They have a car issue, are they able to walk to somebody's house? And this can really be a challenge that unfortunately does not get the attention it deserved of the challenges the rural population can face. They say that change is the only constant in life. And some of those changes into aging are not necessarily negatives. Vocabulary and verbal reasoning tends to improve with aging. But then other aspects, such as mild memory and decline, is common. Other issues with sensory issues, such as vision, hearing. We want to make sure that we are tailoring each patient interaction specifically for that patient. If that patient has hearing deficiencies, you don't want to speak obnoxiously slow, but you do want to slow down. Make sure that you are enunciating, making sure you're giving that patient time to process. They also say using a slightly lower tone as opposed to a higher pitch tone can help patients with hearing deficiencies. And we want to do everything we can to help that patient make sure that they're understanding and keeping up with what we're doing as nurses. Another major consideration with the elderly is unfortunately homelessness. Homelessness is increasing across the country and associated with low income, reduced cognitive capacity, living alone, an inability to work. Or when they say that the Social Security is a fixed income, they really mean it. What Social Security pays is not a lot and is far lower than what the rent would be in many, many areas. Numbers are increasing due to health, economic, socioeconomic status. Higher risk of health problems and mortality go along with this. And the health conditions with homelessness are everything from lack of nutrition related, but also communicable disease. Tuberculosis rates are 10 times higher in the homeless population when compared to the rest of the population. Fortunately, the elderly are much more vulnerable as well, less likely to use shelters and meal sites, and they really do require an interprofessional approach to provide access to healthcare resources, get them the resources they need. Frailty is another common clinical syndrome seen in older adults. More likely to be physically dependent, institutionalized, and this comes from everything from natural aging to malnourished, dehydrated, living alone, depression, and low income. Major risk factors going along with this are everything from disability, multiple chronic conditions, and dementia. And even these is greatly increased with smoking, depression, long-term health problems, underweight, and being unable to rebound from a major traumatic or stressful event. One tool used to identify and assess risk factors for poor nutrition is going to be scales. And this is going to be a nutritional assessment for older adults that measures S for sadness or mood changes, C for cholesterol, do they have high cholesterol? A is for albumin. Is the albumin low? Albumin is a lab test we can use to measure the patient's protein levels, measure their nutrition. The L in scales is going to be loss or gain of weight. E for eating problems such as swallowing, poor dentition. And finally, the last S is shopping or food preparation. Are they able to get out and shop for themselves? Are they able to cook and prepare meals for themselves? And all of these together are going to be able to identify our patients that are higher risk for malnutrition. If identified, look for social services and assistance, such as meal delivery services, dietary or vitamin supplements, and also government resources such as SNAP, Supplemental Nutritional Assistance Program, dental care, and any prescriptions they may have that also could be altering their appetite or interacting with their nutrient intake. Other considerations such as ethnogeriatric specialty or the culturally competent care. If we're looking for long-term care or assisted living, look for assisted living referrals in places with similar cultural backgrounds. It would go a long way in helping that patient feel more at home. Other things, lower incomes could result in an ability to afford treatments, medications, Medicare deductibles, and support is most often found within the family, religious organizations, and isolated geographic or community clusters. It's going to take, there's not necessarily one go-to source for support in a lot of these situations. These patients may be on both Medicare, SNAP, and a large variety of resources and support systems to get them what they need to live a functional life. When looking for social support for older adults, this occurs at 3 levels. The first best source is going to be family caregivers. This is going to be your primary source of support for an at-risk elderly individual. The next semi-form level is going to be clubs, religious or faith-based organizations, neighborhood support, adult daycares, or senior citizen centers. And finally, our last resort is going to be these formal systems, these social welfare agencies, health facilities, government organizations. Most commonly, we would first seek that support from spouses, adult children, especially older adult women age 65 plus, parents, grandparents, life partners. And unfortunately, most people are not prepared for a caregiving experience. Especially I know a lot of you are LPNs. The amount of care that goes into treating and taking care of the elderly is significant. And it can be a major strain and a major responsibility to then place on adult children who may already have other children themselves that they're taking care of. Caregiver stress is a very real phenomenon. Signs and symptoms include everything from irritability, inability to concentrate, fatigue, sleeplessness, social isolation. This can all lead to burnout, negligence, abuse. And again, what are our 2 forms of abuse that are mandatory for us to report as nurses? And that's going to be child and elder abuse, as those are the 2 that cannot report for themselves. That's not to say that you shouldn't or couldn't report other abuse. It's to say that the 2 mandatory to report, child and elder. Social workers can also help prevent this abuse, looking for referrals for things like respite care. Think of this like adult daycare. The daughter is taking care of her elderly father, but she needs a break. She knows that burnout is coming. She's getting worn down. She needs a break. And that's where things like respite care would come in, where it'd be like a short-term nursing home to give her a chance to recuperate. Unfortunately, 2 to 10% of community-dwelling older adults in the United States are abused, neglected, or exploited by their trusted others. And unfortunately, that financial exploitation is much more common than you would think as well. There's actually a sad story in Japan back around 2010. The oldest person in Japan died, meaning there was a new oldest person in Japan. So the local news and politicians all got together and went to his apartment to go congratulate him on being the oldest person in Japan. Unfortunately, when they got there, it was found that he'd died in his bedroom about 30 years ago, and his children had been living there cashing his Social Security checks, or the Japanese equivalent of Social Security checks. While that's an extreme example, Mortality risk is about 3 times higher in these cases of abuse, often due to stress-related illness from prolonged abuse, or if not the abuse, the neglect itself. And for every reported case, 5 go unreported. These victims are unlikely to report mistreatment by the trusted others because they're in isolation, they're depressed, they're elderly. In many cases, they may feel like a burden, feeling shame, guilt, self-blame, or fear of reprisal even. Yeah, there's a reason that a child and elder abuse are two mandatory to report. 90% of domestic elder mistreatment is by family members, unfortunately. Adult children, maybe even spouses. And the risk factors are everything from physical or cognitive limitations. When you get an HEI, one of your big risk factors is going to be confusion. Alzheimer's, Parkinson's is one of your highest at risk for mistreatment. Other things like psychiatric disorders, alcohol use, that lack of a social support around him to report that mistreatment by the immediate family, a larger household, inadequate income. And unfortunately, abusive spouses or partners may either begin intimate partner violence in older age or continue a lifelong pattern of that abuse. In institutions, just as in the home, dependence on others contributes to abuse by staff, visitors, and others. That's another major area of abuse, unfortunately, is nursing home staff. I know here in Ohio we have a new law where the family members can actually legally place cameras. They can pull up on their webcam in their elderly parents' room at the nursing homes. It's a law. That nursing home is legally mandated to allow them to set that up. But at the same time, that also opens a lot of different avenues and other questions of, the privacy of the facility, the privacy of that patient in his room. But then again, that is also in a major way it makes that family feel safer. Is that contributing to the safety of the patient? And there's probably a lot of very tragic and sad stories that made that law necessary. Elder mistreatment can take many different forms: physical, psychological, sexual, financial abuse, neglect, abandonment, violation of personal rights, and just as in any other cases of abuse, it can often be tragic, but especially in the case of the extreme elderly, the confused, that are unable to leave the situation, unable to report it for themselves. Another area not often discussed is that self-neglect. There are a lot of elderly living at home alone that are really, really struggling to be able to just take care of themselves, unable to meet those basic needs, but would still refuse help, especially out of pride. You've been living independently your whole life. One of your major fears would be going to a nursing home. I know it would be for me, and I feel like that's completely understandable. But at a certain point, that they're a danger to themselves. And having multiple untreated medical or psychiatric conditions can also greatly contribute to this risk. Living alone, often in squalor, and they experience higher rates of mortality. For nursing, we can refer them to long-term case management, adult protective services if necessary. There are support services out there. In any case of suspected abuse, report it to those social workers. Those social workers working in hospitals can be extremely effective about the resources and contacts they know how to get a hold of. Before we report these cases of abuse or self-neglect, there are some things we're going to need. That health and physical. We want that patient's current physical status, any evidence of injuries, our screenings for safety plans. Make sure you've got photos with consent of the patient as evidence. And we have documented this thoroughly. And you've both reported it, but you've also reported it in a way you can cover yourself to show in writing that you have reported this to your supervisor. You have reported this abuse to the doc. Because it is very important that you have reported that. Mandatory reporting exists in most states. That adult protective services, law enforcement. Make sure you really know your legal responsibilities and state laws. I can tell you a lot of the laws in Ohio. For Texas, again, keep in mind that NCLEX is a national test. Your textbook is a national textbook. And we're trying to teach to a national standard for those. And ultimately, your scope of practice comes to each individual state board of nursing. If you have any really in-depth questions about Ohio, I could tell you right off the top of my head. If you have any questions about Texas, I'm happy to get into Texas law and the Texas Nurse Practice Act and find any answer you'd want as well. A network of support for older adults, both in the community and in the healthcare agencies. There are a lot of resources out there. State, local, community, government funded. Make sure that we have taken every avenue we could to provide that elderly patient with all the support we can get. Us as nurses at the bedside, we can treat their immediate problems. We can get them healthy, discharged, but unless we've dealt with those underlying issues at home, unfortunately, we may just be sending them back into danger or just setting them up to deteriorate and come right back to us. As far as healthcare goes, Medicare is going to be your not even probably, it is your largest insurance and healthcare provider for the elderly. And again, Medicare is that federally funded insurance program for people ages 65 or older. Well, coverage is limited and there is a certain percentage that they have to pay in. It's a great resource for the elderly, especially when they get to that 65. They have a lot of healthcare problems going on. This is a major support service. There's 4 options for coverage under Medicare. Part A covers inpatient hospital care and partially covers skilled nursing facility care, hospice, and home health care. It's funded through payroll taxes, so available to everyone for government free through the government. Part B partially covers outpatient care, physicians or primary care providers services, home health care, and some preventative services such as mammograms as well. Has a monthly premium and annual deductible, is optional. Part C, that Medicare Advantage plans are offered by private companies approved by Medicare, and it provides Part A and Part B benefits. Finally, Part D provides a prescription drug benefit. This came out in the George W. Bush years. Has a yearly deductible, a monthly premium and co-payment, and lower income patients may qualify for extra help. That's another area that's often overlooked is the cost of prescription drugs here in the United States. It can be, you would be shocked at the amount that some of these drugs cost and how an elderly person on a fixed income is able to come out of pocket and pay for that before Part D. Unfortunately, there is no coverage for long-term care, custodial care for activities of daily living or instrumental activities of daily living, dental care or dentures, hearing aids, eyeglasses. There's a lot of limitations there, but just that major support with the emergency health care. Unfortunately, costs increase with age, functional disabilities, the number of chronic conditions, and the number of hospitalizations can multiply very quickly the cost of treating a person and keeping them healthy. Often confused, but are 2 separate programs, are going to be Medicare and Medicaid. Medicare is the program for the elderly, age 65 and over, where Medicaid is a similar style of government-provided health insurance, but that is going to be based on low income. For those elderly who qualify for both Medicare and Medicaid, they're referred to as dual eligible, and the eligibility for this is going to vary by state. Medicaid pays Medicare premiums, deductibles, and coinsurance, as well as long-term care and home health expenses for qualified Medicare beneficiaries. So being able to add this Medicaid support onto Medicare can go a long way in treating patients in areas that Medicare unfortunately does not cover. The majority of long-term care in the United States is paid for by Medicaid or a private payer. Long-term care facilities. This is many people would consider this their last resort, both for themselves as well as for caring for their loved ones. Unfortunately, it can also be very necessary. Everything from progressive dementia, incontinence, or other major health events can accelerate that long-term care placement. Other considerations is just that stress and burnout on the rest of the family. That daughter may have wanted to keep her dad at home. That's where he wants to be. That's where she wants him. But she just can't do it anymore. The stress and burnout has eventually got too much to where either she can't handle it or they're not able to provide that elderly patient with the care that they need. If you talk to a lot of other long-term care nurses, they'll also tell you that unfortunately patients will deteriorate very, very quickly when they get to LTACs. It's not necessarily the change in care. They may be getting much higher level of care. It's that added stress. It even has its own term, that relocation stress syndrome. And it's that major disruption and confusion on the patient. Cause anxiety, depression, disorientation. Another thing to consider with the elderly is they know what's expected of them. They're in their comfort zone. They may be more confused than they're letting on. And when they get that big jarring move, that big jarring stress, they will begin to deteriorate very, very quickly. I had a grandmother. I still have a grandmother. 92 this year. She made it to about 85, 86. She spent most of her life Midwest up in Michigan. Then my aunt, her daughter, was moving down to Florida, brought her with her. And we think she was pretending a lot more. I'd sit down and talk to her. She still seemed sharp, would make jokes. When they made that move to Florida, she started to become more and more confused. They ended up having to take her keys from her, and she became much, much more difficult to take care of. And I believe it was that major stress of the move. She had been in Michigan most of her life. She knew her whole way around. She was comfortable. She got to a new area in Florida, and just that jarring stress of that move caused her to deteriorate very, very quickly. Another option to provide assistance for those caring for the elderly at home would be an adult daycare. Just like the name sounds. For a caregiver, these options would be a great respite. Give them a break. Let them try to recover. It can be extremely stressful, and burnout is a very real thing with caring for elderly patients at home. In many cases, they need 24-hour care. Other things in the option of working, maintaining employment, being able to go shopping and do errands. How could you do all of that when there's only one of you with an elderly person that needs 24-hour care? And that's where an adult daycare would come in. They provide social and recreational services, assistance with ADLs and supervised setting, and it could really go a long way in helping the elderly patient remain at home as long as possible while still providing support to that caregiver. Another source of support for those elderly still at home is home health care. Transportation can be a very real concern for these patients. Even saying for a wheelchair vans can be very expensive and difficult to get appointments with, but also in the case of just limited mobility, it can be extremely difficult to get them in and out of certain vehicles. And in this case, home health care would bring a practitioner nurse directly to their bedside at home to give them intermittent care. It can be cost effective, though the patients must meet certain criteria, and it's not an alternative for adults in need of 24-hour care. This is for someone who has assistance at home, but can still see a provider right there at the home, making it that much easier. Non-medical services that supplement the home health care, for the case of respite, personal care, and homemaker services, and needs a physician order and required skilled nursing care for Medicare reimbursement. Another service for the support of the elderly is the PACE program, Programs for All-Inclusive Care of the Elderly. This is a government-funded through Medicare Medicaid program that provides services such as prescription medications and wound care, physical, occupational, recreational, and speech therapy, adult daycare, dental care, and it provides care for the adults still living at home age 55 and older. As you can imagine, there's a lot of legal and ethical issues involved in the care of the elderly that can get complex and difficult, especially when you consider the families involved. This is a very emotional time for them, and it can be even more difficult when you have multiple family members that both want to see different options for that patient. Both may believe they have the patient's best wishes at heart, but how do you decide? And in this case, things like advanced directives and living wills would go a long way in helping determine that patient's care. An advanced directive, that living will, is a written legal document written by the patient while they're still of sound mind to designate what they would like to see happen. Versus a healthcare proxy, this is a legal person that elderly person has designated to make healthcare decisions for them, should they be unable to make them themselves. Other ethical issues include things like resuscitation, treatment of infections, nutrition, hydration, and the needs to transfer to higher levels of care. Another initiative currently in play is the Age-Friendly Health Systems model of care. And this This sets out to help address complexity of care and the challenges that older adults face as they age. It's an initiative to build that movement so that all older care is age-friendly. It's guided by a set of evidence-based practices to help reduce or ensure no harm, and it's consistent with what matters to older adults and family caregivers. It really is a program to more focus on the needs of the elderly versus the general population as a whole. The key components of this initiative are what's known as the 4Ms. And these 4Ms are, first, what matters. Where does that patient prioritize their care? What matters most to them? Second M is medications. What medications do they need to remain on? They may have been on many medications throughout their life, but as they're getting older and coming towards the end, maybe some of those medications aren't necessarily necessary and may be doing more harm than good. Mentation, helping that patient to maintain their mental status and slow the progression of things like dementia, Alzheimer's, and prioritize that treatment, along with the final M of mobility, anything we can do to maintain or improve their current levels of mobility. As you can imagine, the care of the elderly is its own unique specialty within nursing, and that specialty is very necessary and unfortunately doesn't get the respect it deserves in a lot of cases. It's a very complex and skilled field, and they're very adept at identifying these common elderly issues such as delirium, acute changes in mental status, and change in functional status. Also, good at identifying that cascade disease pattern. These are more of these classic injuries and issues with the elderly, such as insomnia, sleeping medications, lethargy and confusion, falls, which result in often a hip fracture, decreased activity, mobility, and subsequently develop pneumonia or pressure sores. And unfortunately, that is a very common cascade and sequence of events that occurs in the elderly that can be very difficult, if not impossible, for some to recover from. The nursing management and assessment of the elderly patient, just like with every other patient, our priority is going to be to attend to those primary needs, that bottom level of Maslow. What is their pressing issue? Get those everything they need for ABCs, airway, breathing, circulation, their primary needs. And then from there, we're going to move up that Maslow level to our safety risks. Ensuring that safety devices are used, their canes, their walkers. We're making sure there's no trip hazards in the floor. Also things like allowing these patients extra time to complete tasks. They're moving a little slower. Interview the family and caregivers separately to help identify any issues in the home. The focus of that geriatric assessment is to determine interventions to support and enhance their health, quality of life, improve their function and independence of the elderly, and anything we can do to support them in their unique set of needs. Although their assessment may be lengthy, it's really important that we get a thorough lifelong health history of this patient. From there, we'd move on to things like mood assessment, depression. Psychiatric issues are very real and very common. Also, functional assessments. We talked about those ADLs and IADLs, activities of daily living and instrumental activities of daily living. Their mental status evaluation, their social environment assessment, and that physical assessment. This is all going to combine to determine the care moving forward that this patient requires. One of our unique assessment tools for the geriatric patient is going to be known as SPICES. And SPICES is an acronym, stands for sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. Their mental status is often determined the potential for independent living. And by running this, we are able to determine how much this assistance this patient needs at home and whether they're able to remain at home independently, remain at home with a caregiver, or whether they're going to need to come into varying levels of support from a facility. Falls are a very common and potentially deadly injury for the elderly, and there's many different factors that make them an increased risk of falling. Everything from their medications, infection, that orthostatic hypotension, dehydration, electrolyte imbalances, arthritis, changes in gait, balance and mobility issues, neurological problems, decreased muscle strength, reduced visual acuity, or some combination of all of those factors greatly increase the elderly patient's likelihood to fall. As nurses, make sure we're really assessing dizziness when they stand or change positions, assessing their gait and any changes in their gait, balance, mobility weakness, always keep that bed in that lowest position and do everything we can to prevent falls. Other things like other environmental hazards, like his rugs, slippery floors, keeping that bed too high. I can't say how many times I've come into a patient's room and their bed is still at that highest level, which was the highest comfortable position for the provider, but then it was never dropped back down. And that is a big drop for an elderly patient. Other things like poor lighting, uneven pavement, and improper footwear. Everything we could possibly do to prevent a potential fall. Because for a fall that you and me may bounce from and just get right back up, patient with osteoporosis, frail, or hip fractures are a very common and debilitating injury with these falls. And everything we could possibly do to prevent one of those from occurring. Careful planning will go a long way in helping to improve and maintain their quality of life, maintain that functional independence. We want to identify their strengths and abilities. What do they do well? What are they still maintaining? Include the patients and the caregivers. And again, we want to maintain that sense of control, keep them feeling safe, reduce stress, and everything we can do to support them. There are a lot of special devices and tools we can implement in our care for the elderly. Everything from that sensitive skin tape, using a smaller child-sized blood pressure cuff if necessary, getting that Hoyer lift, getting multiple people to help with a lift to make each move that less jarring and difficult, and modify our approaches based on that person's unique physical, functional, and mental status. Priority safety is always going to be a major concern. Allowing them that extra time, using that adaptive equipment, and being calm, being patient, explaining things in simple terms. Other health promotion and population health issues, things like vaccines. A lot of people think of vaccines as a thing for children, but when it comes in cases of the pneumonia vaccine, this is indicated 65 or older. Reduce hazards in the environment, keeping up adequate hydration and drinking liquids, reducing that sugar and salt, that thinner skin, and they're at greater risk of dehydration from a lot of factors. Giving them 150 minutes of moderate, intense exercise each week, maintaining that proper nutrition, giving them those boost and supplemental shakes if necessary, and making sure they drink it. In a lot of cases, you'll see those bring them that supplement, and they'll just come set it by the patient's bed. Then you'll come in a couple hours later and they've still got the old one. They haven't drank it. Those supplements, they provide those extra calories they need that they're not necessarily getting from their current diet. The hospital is often that first point of contact when we notice there is problems in the care of the older adult. And unfortunately, by the time they've come to a hospitalization, they may have multiple coinciding issues that have been allowed to progress much farther than they should have. Other common conditions resulting in hospitalization, we've talked about falls, but dysrhythmias, heart failure, stroke, fluid and electrolyte imbalances, urosepsis, UTIs, and urinary tract infections are very, very common, especially in elderly females, and finally hip fractures. Identify these risks and complications. Consider discharge needs early. One of those classic NCLEX questions I see out there a lot is you're coming on shift and one of your elderly patients suddenly becomes confused. And out of the 4 options, one of them is going to be UTI, and they want you keyed on that. Does that patient have a UTI? And there's a reason for this. How many elderly females have been allowed to sit there with a raging UTI that was dismissed as dementia, when in reality, they had an infection that was going completely untreated? Discharge planning and transitioning to another facility are another real and often complex task in the care of an elderly patient, because they have a lot of different problems going on, and making sure we're finding that right level of care that they need, and we're not just sending them to a position where they're going to be rehospitalized and come right back to us. Medicare regulations require that this is completed by an RN, social worker, or another qualified person, or a group of a team working collaboratively to make sure we've developed a care plan to transition them through the discharge process. Rehabilitation or rehab may occur in a lot of different areas, everything from acute inpatient rehab, subacute rehabs, or long-term care settings. And this is a result of that decreased function or disabilities may need that they need different services. And this can all lead to increased self-care deficits, higher mortality rates, increased rates of institutionalization, and a decreased quality of life. In the case of a rehab, we are recovering. We have had that issue, we have treated that acutely at the hospital, and now we are sending them to a specialized facility to recover from that problem. There are a wide range of assistive devices that can go into improving the care of the elderly. Those obvious ones, those assistive devices for mobilities, canes, walkers, but also different monitors for heart rhythms, blood pressure, those wandering guards for dementia patients, speech difficulties following stroke, and also think about those feeding assistive devices. They make special spoons, special forks, special utensils that can help that patient still to feed themselves despite following a stroke, following significant neurological difficulties. And yeah, making sure you're aware of all the different tools available to you. I can't stress enough the role that safety plays in the care of the elderly. During blizzards in Ohio or heat waves in Texas, the elderly are usually the majority of the deaths in that. And the reason is that they're due to declining thermoregulation of their bodies. They're unable to deal with that stress. They're unable to deal with the shocks and aren't as resilient as their younger patients would be. These environmental changes also extend to the home. Everything we can do to prevent tripping hazards, like uncluttering the floors, no throw rugs, no extension cords is a big one you'll see in a lot of NCLEX questions. Making sure we've got proper lighting so that they can see where they're going. Also, aiding their sensory, making sure they're wearing their glasses, they're wearing their hearing aids. We've got smoke alarms and fire alarms in place and working, because unfortunately they get a little forgetful generally, and they are more at risk of leaving something on the stove cooking and starting a fire. Also, things for new patients in your unit: clocks, have exits marked, proper lighting, call bells. These are going to go a long way to help keep that patient oriented. Another thing we haven't talked about yet is sundowning, and that has to do with your circadian rhythms. I was a night nurse for a long time, and I don't know how many times I've came on shift, got report, she was great, she's just gets a little cup of pills, she's sitting in there watching Wheel of Fortune right now, and by the sun goes down, she's extremely disoriented. Other things like MVAs, motor vehicle accidents, making sure they're getting the family involved and assessing their driving ability, and we're carefully orienting this patient and identifying any danger that they could be at risk for. Medication use is another major consideration with the elderly. There's very few of them that get up to their golden years and aren't on some form of medication. And we really need to be thoroughly assessing these patients. Everything from assessing the dosages and assessing, are they excreting this medication? Decreased kidney function, decreased urination. Is their bodies processing and excreting this, or is it building up to a toxic level? Other dangers, such as the inability to read those labels. The labels on some of those pill bottles can be extremely small. Do they know what they're taking? Are they aware of what they're taking? And you start talking about, as we said, polypharmacy, where you're on multiple prescriptions. In a lot of cases, they'll have different specialists they're going to, so they'll have 3-4 doctors all writing prescriptions for this one patient. And medication errors, again, doing everything we can to make sure that they know what they're taking, they know when they need to take it, and they can take that medication safely on their own. We have a chart here from our textbook, figure 510, and it just talks about the different areas of the body that are involved in metabolizing and excreting those medications, and also the effects that polypharmacy can have on that patient. Make sure that you're really carefully documenting that patient. You're watching them after they get each med, especially a brand new med. Other things to consider are alcohol and drug use. Often they will be taking alcohol at home, but they'll be embarrassed about it. They won't tell you about it. The elderly, I don't want to say they drink more than the rest of the population, but especially the current elderly age group, they drank a lot more than we did. And make sure that we're really assessing that. We're keeping an eye on those patients' reactions to it. And we're monitoring for changes, because a drug that they may have been on for a long time, if they start getting declining kidney function, they may no longer be handling that drug the way they used to. How to deal with that disoriented or dementia patient who is suddenly progressing to the point where they're posing a danger to themselves or others. A subject we're going to talk a lot about in our mental health course is restraints. And these can be necessary, but we need to be very careful when we're implementing those as well. We're always going to have a doctor's order written right there for that patient, or if we put the patient in restraints for an emergent situation, we're getting that doctor's order immediately. Other things that could be considered restraints. Some facilities will consider all 4 bed rails up. That patient cannot get out of bed. That will be considered a restraint. It can even go beyond that, and you'll see some areas of the country where nursing homes can't use bed alarms or chair alarms because that is considered a restraint. And while that's going to vary by state to state, facility to facility, make sure that you're very careful when you use any form of restraint on these patients, and it is only used in the case of a last resort. Other thing that can be restrained is chemical restraints, drugs. Docs, you'll see, while Haldol shouldn't be given, it is given to the elderly a lot. And again, it is a very effective drug. And when we're sedating this patient for their own safety, we need to very carefully assess that patient. Make sure we're only using it in a last resort, because it is an area that's commonly brought up in malpractice. You are depriving that patient of their liberty, depriving that patient of their freedom of movement. And we don't want to do that unless it's an absolute last resort. Another area we've touched on a bit in the elderly is psychosocial changes and depression. This is not a normal part of aging, though it is extremely common in the elderly. They've maybe lived their life, had a full house full of family. Suddenly they're living alone. Their spouse may have moved on. Their children have moved to other parts of the country. And suddenly they're feeling much more alone, much more socially isolated. And depression is a very major consideration. It's often unrecognized in older adults. 15% of those living at home have manifestations of depression, and even higher in the institutional settings. And this can go along with pain, insomnia, lethargy, agitation, weight loss, and dementia are often associated with depression. Roll out those physical disorders first. You really want to, you see a psychosocial change in your patient, make sure you're very carefully assessing them. As we talked about in the case of UTIs, that's such a classic NCLEX question that as soon as you see a change of mental status, make sure you're assessing that patient, assessing for that infection or UTI. And finally, suicide risk is also greatly associated with the elderly population, unfortunately. Also associated with female gender, divorced or separated marital status, low socioeconomic status, poor social support, and a recent adverse or traumatic event. Another big one is sleep. Inadequate sleep is a very common concern. They're in more pain, they have more aches, arthritis. They're just not sleeping as well as they used to. And that can have a debilitating effect as that sleep debt builds up. Unfortunately, lack of sleep is a very common problem in this country, much more than you may be aware. And really doing everything we can to help that patient sleep and give them uninterrupted stretches of sleep as well. Try not to be coming in and out constantly. See if we can cluster the majority of our nursing assessments and interventions into one trip in to wake the patient and disturb them. Give them as much chance to sleep undisturbed as we can. Finally, finishing up with a couple audience response questions. The nurse teaches a student nurse about healthcare disparities and older adult women. Which statement, if made by the student nurse, would indicate an understanding of the teaching? A. Women have a shorter life expectancy than men. B. Women have fewer financial resources than men. C. Women were not likely to be a caregiver to their spouse. Or D. Women most often have age-related cognitive impairments. And that answer is B. Women have fewer financial resources than other men. In our previous slide, the options, A, women tend to live longer than men. They tend to be healthier than men for longer periods. They tend to have a few more years on us. But at the same time, they also have fewer financial resources, and they also tend to act as caregivers to their declining husband. And finally, our last audience response question. An older adult male is having his blood pressure checked by the nurse at the senior center. When the nurse notes large bruises on both of his upper arms, when questioned by the nurse about the cause of the bruises, the patient responds, "I must have bumped myself," which is the most appropriate initial action of the nurse to take. Ask the patient if anyone has been mistreating him. B. Report the findings to the state agency for elder abuse. C. Question the patient about his living situation and activities. Or D. Reassure the patient that all information will be confidential. And that answer is C. Question the patient about his living situation and activities. We want to gather all the information we can. We don't want to run off and report this immediately. We want to gather as much information we can to thoroughly assess the situation and also to have information and evidence to bring with us should we need to report this. The best approach in this situation is for the nurse to complete a thorough history and physical. That includes screening for mistreatment. Two suggested assessment tools are the Elder Mistreatment Assessment and the American Medical Association's Diagnostic and Treatment Guideline on Elder Abuse and Neglect. Again, I can't stress enough how you see a lot of questions regarding elder and child abuse because it is so important for both you and the patients. That's the two mandatory forms of abuse to report, child and elder. And if you have any hint of abuse, the answer is always going to be gathering information, gathering that evidence, and making sure that you've reported it. And anyway, that's all we have for this chapter. That's probably your biggest one this week. If you have any questions at all on this, hey, feel free. Shoot me an email. Shoot me a text. Happy to run over anything again with you. Otherwise, I'll see you in the next chapter.